When we talk about conduction abnormalities and arrhythmias, we're really looking at the heart's electrical system when it struggles to keep a steady rhythm. These rhythms can range from idioventricular rhythm and asystole to the different types of atrioventricular or AV blocks. They're not just lines on a piece of ECG paper. They represent how well or how poorly the heart is able to pump blood. Idioventricular rhythm occurs when both the sinus node and the AV node fail, leaving the ventricles to pace the heart. The rate is usually slow, somewhere between 20 and 40 beats per minute, and the QRS complexes look wide and bizarre. Because the ventricles aren't designed to set the pace for the heart, cardiac output is almost always inadequate. If the rate drops even lower, sometimes called an agonal rhythm, blood flow to the body plummets. Asystole is even more dire. It's the complete absence of ventricular activity, seen as a flat line on the ECG. There's no pulse, no cardiac output, and without immediate CPR and advanced life support, death is inevitable. In contrast, first-degree AV block is less dramatic. Conduction through the AV node is slowed, but every impulse still makes it to the ventricles. On the ECG, this shows up as a PR interval consistently longer than 0.2 seconds. The overall rhythm is usually normal, and often this is a benign finding, though it can be a marker of aging, increased vagal tone, or medications like digoxin or beta blockers. Second-degree AV block type 1, or Wenckebach, is easy to spot once you know the pattern. With each beat, the PR interval gets a little longer until eventually a QRS complex is dropped. Then the cycle begins again. Many patients tolerate this without symptoms, but frequent episodes can cause palpitations or lightheadedness. Second-degree AV block type 2 is more worrisome. Here, some atrial impulses are blocked entirely, while others get through, but the PR intervals of the conducted beats stay constant. You might see 2 P waves for every QRS, or 3:1, or even higher ratios. Because this can progress suddenly to complete heart block, it often requires pacing. Complete heart block, or third-degree AV block, is when none of the atrial impulses get through to the ventricles. The atria and ventricles beat independently, a situation called AV dissociation. On the ECG, you'll see P waves marching along without any relationship to the QRS complexes. The ventricular rate is usually slow, depending on whether the escape rhythm comes from the junction or the ventricles themselves. Patients often feel weak, may faint, or even develop shock. The definitive treatment is pacing, first temporary, and then, for most, a permanent pacemaker. Management of conduction abnormalities depends on the type of block and the patient's condition. If the patient is stable and without symptoms, sometimes monitoring and adjusting medications is enough. If symptoms appear, the priority is to maintain cardiac output by increasing the heart rate. Atropine may be used, though it isn't effective in type 2 or complete heart block. In those situations, temporary pacing is started until a permanent pacemaker can be placed. If the patient has no pulse, we treat them the same as asystole, CPR, and advanced life support. For nurses, caring for patients with arrhythmias always begins with a careful assessment. We ask about symptoms like dizziness, fainting, fatigue, chest discomfort, or palpitations. We explore past medical history for conditions like heart disease or COPD and go over all medications, including supplements, since drugs like digoxin can actually trigger arrhythmias. We review lab results for things like anemia, electrolyte imbalances, or drug levels. We also pay attention to psychosocial factors, since anxiety can worsen arrhythmias. The physical exam tells us even more. Skin that's pale and cool, distended neck veins, crackles or wheezes in the lungs, changes in level of consciousness, irregular pulses, or narrowing pulse pressures can all point toward reduced cardiac output. From this assessment, we can identify major nursing diagnoses. Impaired cardiac output is a common one. Anxiety is another, since living with an unpredictable arrhythmia can be frightening. A lack of knowledge about the condition or its treatment also comes up often. We keep potential complications in mind too, like cardiac arrest, heart failure, or thromboembolic events in patients with atrial fibrillation. Once we know what we're dealing with, our goals become clear. We want to maintain adequate cardiac output, reduce the number of arrhythmic episodes, ease the patient's anxiety, and make sure they understand their condition and treatment plan. We monitor vital signs and hemodynamic status closely, watch the ECG for changes, and ask patients about symptoms. Continuous monitoring and rhythm strip analysis are often part of hospital care. We pay close attention to medications, making sure they're working, checking for side effects, and keeping serum levels consistent. Sometimes we even use functional tests, like the 6-minute walk test, to see how the heart responds to exercise. At the same time, we look for modifiable factors, oxygen levels, electrolytes, caffeine, or missed doses that may be making things worse. Anxiety is a big part of the picture. Arrhythmias can be terrifying. Nurses can help by staying with the patient during an episode, speaking calmly, and providing reassurance. We encourage patients to talk about their feelings, to keep diaries that track triggers, and to notice when treatments are working. Small successes help patients feel more in control. Education is essential. We explain what arrhythmias are, what the treatment options are, and why medication adherence matters. If a drug affects heart rate, we teach patients how to check their pulse and when to call their provider. If anticoagulants are prescribed, we go over safety, monitoring, and why the risk of clotting is serious. For those with potentially lethal arrhythmias, we help families make emergency plans and sometimes encourage CPR training. In certain cases, such as patients with significant comorbidities or newly implanted devices, referrals for transitional or home care may be appropriate. Finally, we evaluate outcomes. We look for stable vital signs, fewer arrhythmic episodes, lower anxiety, and increased knowledge. We want patients to be able to explain their arrhythmia, describe their medication regimen, and have a clear plan for what to do if symptoms return. Conduction abnormalities and arrhythmias range from mild to life-threatening, but the nursing role is always the same. Understand the rhythm, recognize the impact on cardiac output, and provide care that stabilizes the patient while also giving them the knowledge and confidence to manage their condition. Our ultimate goal is not only to correct the rhythm, but to make sure the patient feels safe, supported, and prepared to live with it.